when you attend to sit in the poor economy, So Gary Wall, I said, oh my God, that's a nice fix, Gary. Highly deserved. So he's been a highly regarded speaker in the Academy for Family Physicians and various forums. And we are very privileged to have him here today for his lecture on headaches in children. Thank you, Gary.
Cell phone and the other one, it might cause well. Oh, it's working. Okay. Okay. Well, thank you very much, Raj. I do remember some of those times that we had. Well, today I thought I would give you a synopsis and a talk of headaches in children. And you might wonder why I picked that particular subject, because I'm talking to grandmas and grandpas here, and most of you uh, maybe had some children and some grandchildren, and might have some of the syndromes that I'm going to go through to talk about the headaches in children. First of all, migraine is a type of headache that is prevalent among women, and it's really the second leading disability associated. And some of the women would come in and say, why do I have these headaches? Where did they come from? And really, they came from children. And I'll tell you about some of the children's problems that sort of foster the headaches at this point. Now, the females and males, the females would have 3 times the amount of headaches than males, and it has to do with the genetics. So if you have an XX chromosome, you have 3 times more headaches than the male that has an XY chromosome. And I often get the question about what about the people, the LGBTQ people that are transitioning. Well, if you're a male and you go to a female, you don't get the headaches of the female, you have the headaches of the male because you have the XY chromosome. On the other hand, if you're a female and you go to a male, you have the same headaches as when you were as a female. You don't get less headaches because you transition to a male. So that's sort of a little interesting uh, introduction anyway. Well, now let's look at the headaches in children. The first symptom of why a patient might develop headaches in the future is through colic. You might say, what? Colic? And what about colic? The episodes that they have at 6 weeks of age, they decline about 3 to 4 months of age. The symptoms include crying 3 to 4 hours per day, 3 to 4 days a week. But what about colic? Intense crying and crying for no apparent reason, extreme fuzziness, and predictable evening 11 p.m. to 2 a.m. in the morning. So if you had a kid that's what happened, it's hard to get up in the morning. It's hard to really get a good night's sleep because this kid is crying. And it's predictable between 11 p.m. and 2 a.m. in the morning. They have facial discoloration. They might have some tension of the body. You pick that kid up and you walk around, it stops crying. You might pat him on the head or the back or whatever. And the situation is that the child will stop crying, but you put him back in bed and the kid starts crying again because it's not 2 o'clock in the morning. So the kid will, in 3 hours or so, get into this particular situation. Well, what are the causes? The causes, this is an early form of childhood migraine. Now, what I'm saying about this is that one of these kids may develop migraine as an adolescent or an adult, but this is one of the syndromes that we see. Now, mothers might say, well, maybe I overfed the kid or I underfed the kid. And really, you didn't do anything wrong. Some people think the colic may be food allergies, but that's not the problem either. And sometimes the patients, the mothers would say, well, maybe we have to burp this kid a little bit more. And they burp them and they do all kinds of gyrations with the kid. And the kid stops crying, put him back in the bed, and he's crying again. And this will happen until 2 a.m. in the morning. Now, here's another syndrome that we see in children that might foster or think about headaches in the future. This is benign paroxysmal vertigo in children. This is dizziness. Usually starts about 18 months of age, and the children have a sudden onset of unsteadiness on their feet, and nystagmus is present. Nystagmus is the eyes go like this, and vomiting may be vigorous when they get this too, and it might last a couple of hours or so. Then the kid gets better and starts walking around like nothing ever happened. We see these kids in the office, and they're perfectly fine as far as the physical exam is present. But this is a syndrome that we see over a couple of months in some children. Cyclic vomiting. This is another one. Episodes of severe vomiting. This occurs in the 3 to 7 year old child, and it starts at the same time each day. This is the kid that you see in the first grade, and they know that he's going to have trouble, so they put him the less put him toward the doorway, usually in the first seat. And what happens at 10 o'clock in the morning, a couple times a week, this kid begins to vomit. Well, of course, the teacher gets a little upset, so takes him to the principal's office, or if there's a nurse there, they would take him to the nurse. And the situation is the kid would get better in about an hour or so, get back to school, and like nothing ever happened. But the thing is about this particular child is that it happens the same time every day that she has it. And so 10 o'clock in the morning, this kid starts vomiting. Again, the teacher gets upset, takes him to the principal's office, that type of thing, and takes care of it. It's the same length of time that happens when the kid vomits once or twice, and the symptoms are pretty good intensity. But when the kid stops crying, then vomiting, then the kid goes back to normal. And all of these syndromes, the kids go back to normal playing or whatever it is. Well, when a headache is made a medical issue, what is the first step? Well, we want to determine why the patients had headaches, and you want to determine if it's mild, moderate, or severe intensity, and you want to know if it's a primary or secondary headache. And if it's a secondary headache, what we call having a syndrome now that is serious, um, people often say, well, what about the CT scan? Well, if you take one of these benign conditions and do a CT scan on these particular kids, 99.6% of the CT scans will be normal. So it's almost, not worth doing a CT scan of these on these particular patients. Well, you want to know if it's a primary or secondary type headache. The primary headache is a nervous system you were born with or acquired, and it's usually migraine cluster or tension headache in these kids, and that goes along in the adults too. I'm not going to discuss cluster headache because that's rare. It's mainly in uh, males. Secondary headaches are caused by something else, like infection, mass, a vascular or trauma type of situation. We use the Snoop 4 program in order to diagnose these headaches, the secondary headaches. These are the more severe ones that we have to do something about. Systemic symptoms and signs, neurological symptoms, in which the kid might have one side of his body might have no reflexes on that particular side. And they usually, when they have a headache, it peaks in about less than a minute. Now, the older age group of 50 or above may get headaches too. And if they haven't had headaches before and they start getting headaches after 50 years of age, that would be an indication to get the CT scan and to figure out what's happening there. If there's a pattern change in the headache for some reason, because usually it's the same type of problem as the patient has a headache, it comes about the same way. But if there's a pattern change, that may be a secondary headache too. Or if position, if is aggravated, if the position that the patient gets up, gets the headache, sits down again, the headache is better, that could be a problem. And it could be precipitated by valsalva or exertion. So the kid or the adult may exert themselves and they may have a headache at that point. One of the things that we need to do is look for papilledema, and that's looking in the eye grounds themselves to see if there's any problem. And if there's some problems in the eye grounds, you might suspect that this particular patient will have a more serious type of headache. Do a mini neurological exam on these kids that we think that have a secondary type headache. You do the tendons, you tap on the arms and the legs, and you see if they're the same on both sides or if one's weak on one side. And you look at the neck. And what I tell the residents is, as I see them, to make sure that they palpate the head and the neck with the stethoscope. And so we're going to feel if there's any problem in the neck, look for bruits, which are sounds, different sounds that are in the neck itself, or some sensitivity. And the other thing I look for, especially if it's a child, is scoliosis. If a patient has scoliosis, this is one of the reasons why they may have headaches. And again, the fundoscopic examination. And again, they have to know how to look in the eye and make sure that they're able to see the back of the eye and see if there's any changes. And in the medical school, Dr. Susan Toms is the person, the ophthalmologist, and to make sure that every one of the medical students knows how to look in the eyes. Now, the headaches, tension, migraine, or cluster. We're not going to discuss cluster headaches. We're going to discuss tension and migraine headaches, which are the types of headaches that we see normally in our age group, children or adults. And what about a tension type headache? Less than about 12 days per year would be infrequent, and usually we don't do much about that. When they're more frequent, 1 to 14 days per month, then they come in for some treatment. And I think that this is important that we make some diagnoses here of the tension type headache and how to treat it. If it's a chronic headache, it's greater than 15 days per month. And these people are really suffering with the headaches. And the duration may be 3 minutes to about 7 days, but usually is in the 60-minute category. Well, you have to have 2 out of 4 characteristics. With a tension headache, you need bilateral headaches, both sides of the head. It has to be non-pulsating, non-pressing, and non-tightening. It has to be mild to moderate intensity, not severe. And it's not aggravated by routine activity. So if we're diagnosing a kid that's coming in for a tension type headache, the question I ask them, when you have a headache, can you run up a flight of stairs? Oh yeah, I can do that. And you're diagnosing the tension versus the migraine type of situation. So not aggravated by routine activity. And they have to have both of the following: no nausea or vomiting. This is the tension type headache. Either photophobia, it could be a situation in which they're seeing spots, or phonophobia, seeing or hearing a sound in their head, in their ear. So these are characteristics of the tension type headache. A tension type headache, it's not localized. It's the whole head. It's not throbbing. It's not worsened by activity, and it's not severe, and no neurological, anatomic, or migraine type features. Treatment: acetaminophen, ibuprofen, naproxen. These are the usual drugs that are there. Aspirin should be avoided in children because of the Reye syndrome, and so we avoid aspirin in the children. But these are the three things that seem to help kids when they have tension type headaches. Now, what about migraine? How does this differ from migraine headaches? The headaches have to have two of the following characteristics: one-sided, unilateral. You remember the tension headache has both sides. The migraine has one side, pulsating type quality, moderate to severe intensity, and aggravation by or causing avoidance to physical activity. This is the person that goes to bed, puts the cover over their eyes, and is not the person that could run up a flight of stairs. So one of the big things with migraine versus the tension type headache. And they have to have at least one of the following: nausea or vomiting. Many of them have vomiting, a photophobia or phonophobia, spots before the eyes, or hearing noise in the ears for a period of time. Now, people often ask, well, what is an aura? What am I talking about with auras? Well, auras are spots that come across the visual field. It starts from left to right, or right to left, or up and down, and they could be zigzaggy type lines, or shivering stars or spots in the eye ground itself, and the vision, and there changes in vision or vision loss over that period of time usually lasts about a minute or two, or they could get flashes of light. And any of you that have migraine know how that happens. Now, there's other disturbances that happen as well. This is a patient who was a reporter, and in the middle of the report, is with the microphone, all of a sudden, her words began to garble. Couldn't talk anymore. She started crying, took her off the set, put her in a chair, and this lasted for a couple of minutes or so. And then she came back to normal. The situation was that was an aura, and that was something that happened to the patient uh, with uh, uh, with speech difficulty. So that can happen too. It's rare, but we've seen that before. Now, treatments in that have efficacy in migraine are usually antiemetics are pretty good. I'm not going to go through them, but just to talk about sometimes if they're vomiting a lot, antiemetics can be of help in these particular patients. They establish efficacy, nonsteroidal anti-inflammatories, and there's a list of them there that can help with the migraines. And we would hope that this would help, but a lot of times it doesn't. We have to get other types of medication. What we want to do with the headache treatment is to abort that headache and have freedom of headache in 2 hours. So we're looking at all of our medications with the idea of getting rid of the headaches within about 2 hours. Or you want to give them something that'll prevent the headaches, reduce the frequency, intensity, and improve the response to acute medication. The American Migraine Prevalence and Prevention, we offer prevention if they have greater or equal to 6 headaches per month, greater or equal to 4 days with some impairment, and greater than or equal to 3 headache days with severe impairment, or they have to go to bed. They do that 3 days in a short period of time with their headache, and these should be certainly looked at with stronger medication. Risk factors for progression. If you have poorly treated acute headaches, these can progress to more obesity. We know that from diabetes and that type of thing. Obesity is also a risk factor